So good evening, everybody. We are here from the EIZOC Secretariat, welcoming each and every speaker, participants, discussion, panelists, and above all, our President-elect, Dr. Jayanta Barua sir. This is an endeavor to improve our panelist PG circle mostly, so that our ARC chairman, Dr. Chingsui, is taking all pain to coordinate different subjects and the speakers from different states of the EIZOC. May I now request our President-elect Jayanta Barua sir to give the welcome remarks, which will be followed by directly to Dr. Chingsui, and we will continue with the program.
Good evening, everybody, and I welcome you to this ARC seminar today. I'm looking forward for a very interesting and detailed seminar, and we'll be hearing. I personally heard a lot about Dr. Soham, but today I will be just listening to him, waiting to rather listen to him. And ARC has been a great endeavor, and a lot of PG people, students, practitioners are really benefited by this, and whole credit goes to Dr. Chingsui. Thank you, Dr. Chingsui, for making such a big effort to coordinate everything and bringing out this fine webinar every month almost. Okay, with this I pass it on to Dr. Chingsui. Thank you.
Thank you, sir. A very good evening to all the respected speakers, moderator, and the panelists, and their dear residents, and our EIZOC office bearers. Without wasting much time, let us go to the this thing. Let me take the honor of introducing our moderator of today's webinar, Dr. Professor Jayashree Dora, who Madam has done her MBBS and MS from MKCG Medical College, Berhampur, Orissa. She has been working as a faculty in Vimsar, Burla. She had been the HOD of the Department of Ophthalmology from 2012 to 2022. She had been the in charge medical superintendent of the same hospital from 2018 to 2021. She had also been the dean and the principal of the same medical college from 2021 to March 2024. Currently, she is serving as a professor there in the Department of Ophthalmology. Madam Jayashree Dora had completed her long-term fellowship in cornea and anterior segment from L.B. Prasad Eye Institute, Hyderabad. She had done numerous short-term fellowships in SICS, phacoemulsification, and pediatric ophthalmology. She is a member of the AIOS, EIZOC, Equine, ISMICS, DOS, OSOS, and the WOS. She had been the immediate past president of Ophthalmological Society of Odisha. Madam Jayashree Dora had won numerous awards. To name them a few, National Eye Award as Best Ophthalmic Surgeon in the government sector for the best performance in NPCB on World Sight Day in 2007. She had also won the Equine Gold Medal in 2015-16, the Sushrut Saman at the 5th National Assembly of Federation of Ophthalmic Teachers of India in April 22. And she has been felicitated by various organizations. Madam has presented various papers in the international forum like WOSC, the Abu Dhabi, and the Asia Pacific Academy of Cataract and Refractive Surgeons in Singapore, and in Tashkent as well. Besides various national and state conferences, Madam also has numerous publications to her credit. So I hand over the proceedings to Madam Jayashree Dora to further conduct the webinar. Madam Dora.
Good evening, respected President, sir, and all the office bearers of EIZOC. And now I'm going to introduce our panelist of today's session, Dr. Nidhi Gadkar. She is a consultant at Kashyap Memorial Eye Hospital, Ranchi. She has done MS DNB FRCS in Glasgow, ICO and FICO Cornea Fellowship. Welcome, Madam, Dr. Nidhi Gadkar.
Hello,
to our today's webinar. Now, our next panelist is Dr. Abhishek Ranjan, who is presently working as assistant professor at Nalanda Medical College, Patna, director and consultant, Brightside Eye Hospital, Patna. Dr. Abhishek Ranjan has done his MBBS from Darbhanga Medical College, Darbhanga, Bihar. Did his MS ophthalmology from Darbhanga Medical College, Darbhanga. And he has done a fellowship in LVPI Hyderabad in comprehensive ophthalmology and cornea and anterior segment. He has had got awards. Dr. Ajit Sinha Gold Medal in 2019 and Dr. A.K. Prasad Gold Medal in 2021. He is presently working as assistant professor at Nalanda Medical College, Patna. And his special interest is in corneal infections and ocular surface disorders. Welcome,
Hello,
Dr. Abhishek Ranjan.
Hello, ma'am. Hello.
Hello. Now, I would like to introduce our speaker, Dr. Soham Basak. Dr. Soham Basak is an eminent ophthalmologist. He completed his MBBS from Kasturba Medical College, Manipal in 2012 and he did his master's in ophthalmology from Arvind Eye Hospital, Madurai in 2016. And followed by he did his long-term cornea fellowship from Disha Eye Hospital, Barrackpur, and a short-term ICO observership in cornea at Massachusetts Eye and Ear Infirmary, Boston. He is currently working as cornea consultant at Disha Eye Hospital and is involved in Purva Eye Bank. His interests include lamellar keratoplasty, lasers for corneal pathologies, and eye banking. He has presented in various national and international conferences, and he had got Achievement Award from American Academy of Ophthalmology. He has over 20 publications in various peer-reviewed journals and has contributed to 3 book chapters. Dr. Soham is a reviewer of IJO and Cornea journal. Welcome, Dr. Soham, to today's webinar as a speaker in evaluation of dry eye. I would like to introduce also the residents who are participating today actively. Dr. Ramavati Hari from RG-ARC Medical College, Kolkata. Dr. Akshay Thakur, RIMS, Imphal. Welcome. Dr. Renuka Thakua, RG-ARC Medical College, Kolkata. Dr. Sanjit Kumar, Nalanda Medical College, Bihar. Welcome. Dr. M. Tharani, RIMS, Imphal. Dr. Rajanandini, Nalanda Medical College, Bihar. Now, over to Dr. Som Sarkar. Please start the seminar today.
Good evening, everyone. Thank you for the kind introduction, madam. My warm welcome to all the EIZOC seniors present here and the moderators and panelists. So, and a special thanks to Professor Ching Sui for inviting me to this talk. So I'll be talking about just the evaluation part of dry eye because this is something which we see every day. A big chunk of our OPD clinic are dry eye patients, and also we need to do a good dry eye evaluation before any form of cataract surgery or refractive surgery where the patient expectation is very high and dry eye can really have a lot of impact on it. So I've tried to keep the presentation as practical as possible. Hope my slides are visible.
Yeah.
Yes.
Okay.
Yes, Dr. Som.
So I will also be talking about lots of products and devices, but I have no financial interest to declare. So a lot of this presentation is based on what we know from the TFOS DUCE 2, which is pretty much followed for all the things that we know about dry eye. So if we look at the definition of dry eye, we have to look at three things. One is tear film instability, the hyperosmolarity, and ocular surface inflammation and damage. So all our dry eye evaluation should be sort of tailored to so that we can detect these three things, which are key part of the definition of the dry eye diseases. And also we need to do evaluation rather than just labeling someone as dry eye just by listening to their symptoms. It is also important to arrive at a diagnosis, differentiate dry eye from the masquerades. It's very commonly from the allergic group of diseases. Subtype it because the therapy differs. Understand the patient complaints, the severity, risk factors. And then finally, evaluation will also help us in guiding the therapy and also modifying the therapy once the patient comes for follow-up. So, and it is, as I was saying, it is so important, especially for a cataract and a refractive preoperative patient, that the ASCRS, they actually have an OSD algorithm in place, which they encourage all the surgeons to sort of follow before taking up any patient for surgery. So if you look at the diagnostic flowchart that is there, recommended by the DUCE 2, first we have the triaging questions. So this is primarily history taking, can be aided by questionnaires. After triaging questions, we begin to suspect dry eye. Then we look at certain risk factors, be it ocular or be it systemic risk factors. Then we move on to the diagnostic tests. So it can be the questionnaire scoring that will give us one clue. And then finally, we have any one of these three things. So either a tear breakup time, preferably the non-invasive breakup time, if not, then the fluorescent breakup time, tear film osmolarity, and ocular surface staining scores. So this then definitely gives us a diagnosis of dry eye. And then for subtype classification, we move on to the evaporative and the aqueous deficiency. Now, this is a wall of text which basically follows that diagram that you see in the publication. And in essence, this is all that you need to know about a tear film evaluation. So we can pretty much end the talk here and say that's all, folks. But we'll go into deep dive and see each of these points one by one. So we can classify these evaluation tools as the questionnaires, then coming to the clinical examination. So we have got a slit lamp examination, followed by the clinical tests. Now we have the device-based tests coming up. Sometimes it has to be augmented by blood tests. And then finally, we have the research tests. So these are the microscopy-related tests and the tear film biomarkers. And the devices that we have currently are basically the Lipid view device, which basically gives us the lipid layer thickness, meibography, blink dynamics. And then we have this combined tear film analyzers. So these are something like IDRA, Lacridiag, the keratograph 5M. So they have a non-invasive breakup time, meibography, lid margin imaging, meniscometry, all these combined all in one. And also it is important to do imaging if you have the means or if your institute has it, always encourage imaging, because many of these subclinical types which are not detected by a regular slit lamp examination can be picked up on imaging. So coming to questionnaires, this is actually a very underutilized tool that we have. It helps us understand patient complaints better. And also patients can understand what symptoms can be actually attributed to dry eye diseases. And we can always hand them out as a self-administered questionnaires when the patients are there waiting. And the common ones that are used are the OSDI. This is developed by Allergan, DEQ5, SPEED. These are the commonly used ones. And they usually look at the symptoms, the frequency, and the severity of symptoms. And then you have a grading system. And this is what the OSDI looks like. So the OSDI was also used initially when the restlessness was under trial. So this was developed by Allergan. And the cutoff whether to start restlessness or not was based on partly on the OSDI score. So we can also see that the questionnaires can help us guide the therapy as well. Coming to the clinical tests. So there is actually an order to doing this. You cannot just go in randomly. The idea is to move from the least invasive to the most invasive test. So if you have a device that does a non-invasive breakup time, well and good. That should be the first priority. Next comes the tear film osmolarity. This is a test which is done very less frequently. Then is Schirmer's, followed by fluorescein breakup time and ocular surface staining. So this is preferable to follow this order. And if you're doing dual staining, we'll have to wait between the two stains. In slit lamp examination, we have to actively look for signs and symptoms of dry eye. So look at how shiny the corneal surface is. Look for tear film debris, which sort of float around with each blink. Look at the congestion, especially the superior bulbar congestion, because that can be something like a superior conjunctivitis, SLKC basically, superior limbokeratoconjunctivitis. Look at the corneal epithelium, look for punctate epithelial erosions. Look at the lower lid for the tear meniscus height. Look at the upper lid for what is known as the lid viper, basically the posterior margin of the upper lid. Look at the formation of conjunctival folds, maybe conjunctival chalaces, filaments. And separately for meibomian gland dysfunction, so look at the meibomian gland opening. So these are basically the glands which are blocked. So they have got this thick secretion which is solidified on top. So basically a cap of meibomian gland, meibums basically, which is preventing the outflow. Then you can have sort of these fibrosed glands, and you can have abnormal opening of the glands. Instead of the gland opening in the lid margin, they're opening on the conjunctival aspect of the lid. Additionally, we have to look at the expression of the meibum, whether it is a clear, cloudy, or opaque expression. In that, we can have something like this. The blue device that you see, it's basically a spring-loaded device. It's a meibum expressor, which sort of allows us to give uniform pressure on the lids. And also, you have to look at the quality of the meibum. So after you have done gland expression, ask the patient to blink. And then if you're seeing a lot of debris, so that automatically means that it is a poor quality of meibum. Now coming to the tear film stability. So non-invasive versus fluorescein breakup time. So fluorescein breakup time nowadays is less preferred because it is highly variable due to the volume of the dye used. And also it is observer dependent because most often we do not use a stopwatch. So the timekeeping is usually arbitrary. Even I'll admit that in the clinic, I do just 1 to 10 counting in my head. And anything less than 10 is equal to an unstable tear film. So what is new in this is the use of a yellow filter and also looking at the pattern of the breakup time to subtype the type of dry eye and manage accordingly. So coming to the yellow filter, so this is how a normal fluorescent breakup time fluorescent will look like. So you've done stained the eye and you're seeing it in cobalt blue light. But what happens when we apply a yellow filter to the objective part of the slit lamp is the staining becomes much more dramatic. So the conjunctival staining, which was not very obvious in just the cobalt blue, becomes much more prominent in the presence of a yellow filter. So this is how a yellow filter looks like. Many of the newer slit lamps, especially the Zeiss ones, have it inbuilt. However, you can just simply buy it from Amazon also. It's something like a 510 pass. So it will cut off all the blue light and allows only the fluorescent parts to really stand out. You can just hold it in front of the eyepiece of the slit lamp and then observe the patient. And the second thing, that this is from the Japanese Dry Eye Society. So what they have done is they have really looked at the breakup pattern, and they have classified it as these few groups, like the area break, spot break, line break, and dimple break. So what they have to say is basically the breakup pattern is dependent on the type of dry eye, dependent on the lid function, and also dependent on the quality of the tears. So this can help us classify the tears, classify the dry eye type, and also we can direct the therapy accordingly. So this is something which is very new, and I highly encourage everyone to start doing it in the clinic. This can be done very simply. Then coming to the non-invasive breakup time. So this is basically device-based white Placido ring or a grid pattern is basically flashed on the cornea, and then the camera detects for any distortions in these lines. And basically that gives the distortion, and then the computer makes a graph out of it. Then the next part is looking at the tear meniscus evaluation. So this, in your slit lamp, definitely a tear meniscus is visible. So we have to look at the light reflection in the lower part of the, just above the lower lid. With fluorescein stain, definitely it becomes better visualization, but also it adds to the volume. So it's not really recommended. Otherwise, all these tear film analyzers, they can measure it down to 0.0 millimeters. And also you can use your OCT to measure it. So this is the OCTs. This is actually flipped 90 degrees. So this is the corneal surface here, and this is the lower lid margin. So you can basically make out a thin line here, which shows the tear film meniscus. And from here, we can use the calipers to measure the tear film height, tear meniscus height, and the tear meniscus depth. Then coming to Shermer's test. This is a very variable test. And among the clinical tests, clinically, this has got the least relevance. But however, this is something very easy to explain to the patients. Instead of telling them about breakup time, that the tear film is unstable, they easily understand that, okay, the strip was supposed to get wet till 15, and in my eyes, it has got wet till 8. So I have dry eyes. So what is new here is, this is from Madhu Instruments. It has got a blue pigment, so the readout becomes very easy. And this is something historic. This is a phenol red thread test. This is no longer performed. Then coming to the tear film osmolarity. So normal range is between 295 to 305. Anything more than 308 or an inter-eye difference of 8 indicates high osmolarity, and some indicates basically going towards dry eye. So this is the only device available commercially now. This is a tear lab analyzer. So it has got basically something like your diabetic glucometer. So this part is basically a small capillary chip, which is detachable. So you do one test and then you detach it. It comes in 2 handles, ideally 2 readings, both eyes to be tested separately. And after testing, it has to be returned to the console, and then a readout comes in the screen here. It is not done routinely, mostly because how expensive it is. So each of these strips, I am not sure of the recent prices, but when I took it for demo maybe 5 years back, each test would cost 600 rupees. However, tear film osmolarity is actually important because, again, we can sort of choose therapy based on it. Anything in high osmolarity, we can add the drops containing osmoprotectants. Now, coming to ocular surface staining, this is probably the most important test that can be done in the clinic. So either fluorescein, rose bengal, and lissamine green. Among these, fluorescein and lissamine green are the most preferred ones. So fluorescein staining, basically, anytime where cellular integrity is compromised or there is disruption in the intercellular junctions or defective glycocalyx, there will be staining. Rose bengal selectively stains cells which are unprotected by the glycocalyx and dead or degenerated cells. Lissamine green is only a vital stain. So it stains only the damaged cells, irrespective whether there is mucin or not. And among the rose bengal and lissamine green is better tolerated. Fluorescein in the clinic, better to apply it just in the lateral, just close to the lateral canthus, so that you do not get any sort of iatrogenic staining of the bulbar conjunctiva. Optimal viewing is after between 1 to 3 minutes after putting the dye in. And after you have wet the strip, just shake off the excess fluid and then just touch it once and ask the patient to blink few times. Lissamine green, ideally separate strips to be used because the pigment present is very less, and allow for some time after you have wet the strip, allow for some time for the pigments release, then apply it on the patient's eyes. Optimal viewing is between 3 to 6 minutes. And this is currently what is recommended for detecting a lid viper epitheliopathy. So these are some of the representative images. This is in diffuse imaging. So you can see the dull appearance of the cornea. In fluorescein stain, there is a very diffuse kind of staining all over the cornea. Rose Bengal is picking up stain both on the cornea and on the conjunctival surface. So basically, this denotes a lot of goblet cells damage. So this is causing deficiency of mucin. And Lissamine green is basically selectively staining all the cells which are damaged. So this can also stain both the cornea and the conjunctiva. These are some other examples. This is someone with contact lens use and also on thyroid medication. So there is staining of the corneal surface, conjunctival surface, and also staining of the superior bulbar conjunctiva, something indicative of SLKC elements. This is someone who spends a lot of time on the computer, coming in for a LASIK workup. However, when we do a dry eye, we see a lot of these dry spots and punctate epitheliopathy in the cornea. And look at this tear film on the image to the left. So there is, you can see the tear film is very uneven. So there is a lot of evaporative component present here. So ocular surface staining, there are a lot of these grading and scoring systems available. Primarily, this is of academic use. In clinic, you can just follow a mild, moderate, severe. However, look at the location of the staining. Now, what is new in staining is lacrimal gland staining. So this is very important, especially for the secondary Sjogren's group of patients. So this is someone who is present on rheumatoid arthritis medications. The surface appears dull. You can see some amount of rose bengal staining present. However, if we go in and stain the lacrimal glands directly, ask the patient to look down and towards their nose. So that, and lift up the upper lid, so that exposes the bulbar part of the lacrimal glands. Go in with a fluorescent strip and smear the dye directly over the lacrimal gland. So what you will see is some of these, it will look like basically a Siedel's test. So these duct openings will appear and you can make out the tear film secretion happening. Again, I highly encourage all of you, especially the residents, to go and do it. And if you take basically serial photographs or videos, you can sort of back calculate how much tear is being secreted in unit time. And this is basically very poor in the Sjogren's or the cicatrizing group of diseases. Then coming to lids and lashes. So we have to look at signs of Demodex infestations, lid margin smoothness versus lid margin keratinization, any lid margin deformities, and also the lid functioning. So many times dry eye patients will complain of blepharospasm or inability to open their eyelids. They'll say that their lids are closing, they're feeling unable to open them easily. So this is to be differentiated from a blepharospasm patient and also ALO, that is apraxia of lid opening. So this is something very important we have to keep in mind. Now coming to lid viper epitheliopathy. So lid viper is a concept, basically the posterior margin of the upper lid, which basically helps in spreading the tear film, that is known as a lid viper. And that is normally very rich in goblet cells. However, with dry eye, there is loss of goblet cells and we can stain that part using vital staining, especially Lissamine green. Anytime the staining is more than 25 millimeter or 25% of the sagittal width, that is indicative of a lid viper epitheliopathy. That means the lid margin is also affected. Then coming to the meibomian gland dysfunction device-based evaluation. So two components basically we are looking at. One is the functional part, that is the blink dynamics and the lipid layer thickness, and the structural part, that is the infrared meibography. So lipid layer thickness the measurement is based on a white light interferometry. White light is shown on the corneal surface, and we get like basically an oil and water appearance. So colors are seen, which is picked up by the device, and then that is transferred as from the wavelength that is transferred as how much thick the surface is. And also there is the blink dynamics. So normally, we look at the video playing. With every blink, there is this, you can make out the colors that are spreading over the corneal surface. So that is how a normal lipid layer should appear as. And with partial blinks, where the upper lid is not touching the lower lid, so there is less spread of the lipid layer. So this is present in LipiView. It basically measures how many times the blink is done over a 20-second frame, and also records the change in lipid layer thickness along with it. And also, if we look at the lipid layer thickness, so a low lipid layer thickness will appear dull grayish in color, whereas a high lipid layer thickness will appear bright and multicolored. And also you can, if you're seeing want to confirm therapy, you can sort of apply these lipid containing eye drops and really see the difference, how it is forming. So the one on the videos on the left are before putting the drop, and the one on the right are after putting the drop. So the difference in the colors basically, which indicates lipid layer thickness, is quite obvious. Then the other thing, new thing here is something known as a comfort after blink. So this is a new device from Alcon, which basically checks how comfortable we are after blinking. So ideally, after we have blinked a few times, we should be able to comfortably open our eyes for 10 seconds. So this device plays a video for 10 seconds, and anytime we are blinking prior to 10 seconds, it will give a readout of that. So this is a very simple way of sort of detecting any tear film instability. Now coming to infrared meibography, so we are looking at the meibomian gland anatomy. So a normal gland would look like this, multiple elongated glands, and you can make out the individual acinus and also the gland openings. The signs of meibomian gland would be something like a gland truncation, where the glands become short, gland tortuosity, where the straight formations are no longer present, and blocked ducts with closed duct gland dilatation. So this is a blocked duct. You can see that the opening has become really thick. That is because the gland opening is blocked and all the secretions are collecting here, and slowly that is leading to inflammation. This is a typical LipiView report. So we have a readout of the lipid layer thickness, number of partial blinks, and how the lipid layer thickness is varying with each blink. And also some examples of a meibography patient. So here we can see gross dropouts in the lower lid, hardly any glands present. This is a young child with lot of gland tortuosity, you can see, and lot of dropouts in the lower lids. This is again extensive dropout with very falsely high lipid layer thickness. So this is due to the thick abnormal kind of meibum secretion that is happening. So this, don't rely on the values blindly. We'll have to correlate it with the basically clinical picture. Now coming to other history taking, ocular history taking, certain drops, especially the anti-glaucoma groups, some of the topical decongestants, and some of these antimicrobials, which we are using for ulcer treatments, can cause surface toxicity and lead to dry eye. And also you should be asking patients about contact lens use. So this is a patient on anti-glaucoma medication for a long time, the prostaglandin analogs. And you can see that they have some amount of conjunctival and corneal staining present. Medical history taking is very important. We should actively ask about arthritis, especially the small joint pains and other rheumatoid group conditions. Ask about dry mouth and difficulty in swallowing, because secondary Sjogren's is actually a very common entity in our clinic. Also conditions like vasculitis, group of diseases, and graft versus host disorders are also risk factors of dry eye conditions. Many systemic medications can cause dry eye. So if you are seeing anyone with moderate to severe dry eye, always ask for a list of the medicines that they're taking on a regular basis. And if you're suspecting that some of them might be worsening symptoms, write a note to the respective physician who is treating that part, be it the medicine or the endocrinologist, write a note to them about whether it can be changed to some other alternative. Some of the main groups of drugs which are known to cause dryness are the antidepressant, antipsychotic agents, many chemotherapeutic agents, systemic isotretinoin for the skin disorders, long-term systemic antihistamine use, and the gliptins, which are used for diabetes patients. So this is a huge list of all the possible drugs which are reported to have caused dry eye in various severity. So as a ready reckoner, you can always keep a printout of this in your clinic so that you can cross-verify. Then coming to blood workup, this is not entirely our domain, but we can send for workup like RA factor, ANA, ANCA profile. But ideally, better to take help of a rheumatologist or some physician. Then coming to the research and rarer investigations. This is just for academic interest. So we are now looking at tear film inflammatory biomarkers, interleukins, TNF alpha, then also the T helper 1 and 17. So these are basically biomarkers which can detect and differentiate between the types of dry eye. So it would help in guiding therapy and understanding the pathophysiology. And the other rarer tools would be the tear film ferning pattern. So this is because of the presence of mucin. If you take a drop of tear and put it on a glass slide and allow it to dry slowly, normally we get this ferning pattern. Anytime the pattern is distorted, that is indicative of poor quality of tear films. Impression cytology would give us clue about goblet cell damage and squamous metaplasia. Confocal microscopy would give us clues about what is the effect of dry eye on the various types of the corneal cells, be it the epithelial cells. Sometimes these dry eye patients have a lot of allodynia. So corneal nerve changes might be there. Some limbal cell, stem cell changes might be there. So confocal would help in that. And then finally coming to future and emerging technology. So lab on a chip is basically an upgrade of the TR labs that I showed before. So you'll have something like a glucometer-like capillary thing. You take a tear film and it would give a instant readout of the tear film biomarkers that are present. So Dr. Rohit Shetty's group at Narayan Nethralaya and Grow Labs, they're looking at some of these devices and making it easily accessible. And then these are the ultra high resolution OCTs. So these are probably soon we can expect these to be available commercially. So these give very high resolution images of the, not just the cornea, and also the precorneal tear film is visible. So you can measure the tear film level and look at the corneal, any irregularities of the cornea and the tear film, and a reconstruction would tell us about how the surface is, both of the tear film and the corneal epithelium. Finally, some practical tips for all. So whenever you're sitting in the clinic and looking at a dry eye patient, actively look for these diseases and take a good systemic and ocular history. Look at the surface, especially the upper conjunctival surface. Make a habit to express the glands, because that is, MGD is often missed. And the clinical tests that are commonly, which we can do all of us can do easily, are something like the meniscus height and fluorescent breakup time, ocular surface staining. No need to buy a new slit lamp, just get a yellow filter that will really enhance your views. And Sharma's test primarily for explaining it to the patient. Mubography normal devices are expensive, but we can see make our own basically. Any of these instruments where there is an infrared camera can be doubled as a mubography image. So this is an autorefractometer. All of us have this. So you can just invert the lids and use the joystick to focus on the lids, and you will be able to visualize the meibomian glands using the autoref device. And also, you can consider handing out questionnaires in your waiting area. So that really sort of primes the patient before they come and see you. And finally, this is something which has come up earlier this year, or maybe late last year. So this is something which is known as a dry eye wheel. So you can go to this website, just type out dry eye wheel. So this is an interactive wheel which makes our job easy in the clinic. So what it does is it divides the entire management, not just diagnosis, entire management of dry eye into three circles. The bronze, which can be done very simply by everyone in the clinic. The silver ones, which are the moderate level, and then the gold ones, which are like the highest level of treatment. So this is something which you can keep a handy printout on your desk so that it is easier for you to evaluate the dry eye patients. So really take your time. Something like doing a dry evaluation is quite enjoyable. I mean, you can really see all these very interesting findings in the clinic. Thank you for your kind attention. And this time for real, that's all, folks. Thank you very much.
Thank you, Dr. Soam, for describing evaluation of dry eye very nicely. And we have discussed every aspect of evaluation of the dry eye. And residents should start doing evaluation in OPDs with available devices. That newer device-based is not possible in all settings.
It's just clinical. Yeah. That's why I was focusing on the clinical part. You don't need those devices.
Yeah. So very nicely tested. Thank you. And now, Dr. Abhishek, would you like to give your opinion?
Very nicely described evaluation of dry eye. I think Soham has done a good job in collecting all the possible tools for dry eye to evaluate in the clinics, whatever possible day to day and whatever the new devices we can use daily. The certain new things I have also learned today, like lacrimal gland staining. It's a really new thing for me also. I think so. Just I want to one question regarding that. What is the clinical implication of doing that lacrimal gland staining in our clinics?
Right. Thank you, sir. So one is basically sometimes the aqueous deficiency dry eye. So this basically is a very good confirmation for that. If you're doing a lacrimal gland staining, so credit to basically Dr. Swati and Sayan sir for describing this technique. And so many times aqueous deficiency, there is like evaporative dry eye, there are definite ways of detecting it. But aqueous deficiency, other than the tear volume, so basically you have to rely on tear meniscus height, indirect evidences. So when you're staining it directly, you know that the lacrimal gland secretion itself is low. So if you actually stain in something like a SJS patient, you may not see any gland opening there.
Okay, so that is basically staining the opening of the gland and according
opening
to the
of the gland.
Yeah, according to the
so you ask the patient to basically look towards the nose. Okay. And when you lift it up like this, so that basically this movement exposes the bulbar part of the lacrimal gland.
Okay.
It's actually quite nice. It appears like just small streams will appear. Once you have stained, you can make out the glands opening initially, that will be bright green. And as the tear secretion starts, so small waterfall-like streams will come. It basically looks something like a Siegel's test.
That is definitely the things that has to be seen in
yes. So I highly encourage everyone to just try it out tomorrow in your clinic. Yeah. It's a very simple thing to do.
Yeah. The other thing you have shown that yellow filter, use of yellow filter to see the tear film breakup time. So I think nowadays the slit lamp is also having some yellow filter. Yes. So if it is inbuilt, then there is no need to put any yellow filter for that.
No. Most of the newer slit lamps actually have a yellow filter inbuilt now.
Yes.
But if you do not have, you're using an older slit lamp, you can just use it and you have to hold it with your hand in front of the, basically where the other side of the eyepiece, basically.
Just something like, I mean, what you're doing, when you're doing the IDO and then you all the lens.
Yes, sir. Yes, sir.
Something like that, yeah. That's a very nice one. The yellow filter was something, I mean.
So there are some very nice videos. I have not put the videos. The Japanese Dry Eye Society, they have very nice videos of those patterns that are shown, the breakup patterns. So they're really going very strongly about that. Instead of doing anything else, they're just looking at the tear film breakup pattern and diagnosing and treating based on that. So again, something which we can really look into. It's something very simply that can be done rather than investing in the high-end devices.
And also using auto-ref also for
Yes,
evaluation
yes.
of dry eye.
So
Yes,
any
yes.
infrared
That's
camera will.
that's a wonderful input, actually. You know, I mean, we didn't think about it, actually. You know, that so many of our equipments have infrared rays, actually, which can be used for this mammography thing.
Even OCTs also, but OCT, the image comes slightly smaller. The auto-ref is easier to handle with the joystick.
Okay. Dr. Nidhi Gadkar,
Yes, ma'am.
do you like to give your
Very comprehensively covered all the examination. I want to ask that how often do you do the lippy view reports for the patients? And what is your take on the lippy flow and IPL or mevothermoflow treatments in patients having MGD? How often would you, as an prescribe treatment like that? And when will you recheck the result on the lippy view? Or should we do it on every visit, like maybe Sharma or a breakup time? Or we have to give certain time intervals between the visits to redo such tests and procedures?
Right. So for the mebography test, basically, so anytime I usually get a referred patient or someone who has visited multiple doctors, then I do it additionally. So one is, it is a diagnosis for me. Second is, it really helps in patient counseling. Once they see what a normal gland looks like versus their gland side by side, that gives them that impact that, okay, I have this. And because the chronicity of the disease is something which many patients really don't understand, that dry eye is a chronic disease, that they'll have to live with it. So that really helps in the counseling part of the patient. I mean, I would not. And once you have that, then having like advising them for one of any of these MGD treatments, be it LipiFlow or IPL, both of them work equally well. So then that also becomes more convincing. So those are usually reserved for patients with like a moderate to severe dropout, not for extensive dropouts. That usually doesn't work. But moderate to severe dropouts, definitely you can offer them the therapy. If they're not getting better with just the normal medications in any form, drops, ointments, oral medications. So this is an additional therapy. And our experience over the last almost 5 years now that we have the LipiFlow devices in our hospital. So about 2/3 of the patients, they report a benefit after the therapy. And in terms of repeating the test after it, maybe you can repeat it at least, like give a minimum gap of 3 months, because prior to 3 months, I do not think there will be any noticeable difference. But there is a publication which talks about how the glands have elongated. So basically the blocked glands, which had not completely atrophied. So after a LipiFlow therapy, so that the blocked part really opens up and you can see gland elongation on serial mebography after the LipiFlow or IPL therapy. So that is also very encouraging to see. You can actually show the patient that, look, actually anatomically also you are showing improvement.
residents?
Any of
If
the
any have
residents?
any doubts, any
So we encourage you
residents?
to actively participate, and you have some questions for the speaker or any of the panelists. Please, Dr. Akshay, you have something to ask?
Resident?
Sir, I'd like to ask one question. Usually we see in cases of moderate to severe dry eye, especially in the patients with autoimmune conditions like Sjogren's. So there can be some confusion if the patient is actually coming with dry eye or it is some allergic condition. So how do we differentiate between those two?
So if you look at the immune group, mostly those would be the dry eye part. And ocular surface staining is something that will help you here. And history taking. So this is a very common thing that has been followed from years together. So the itching part, if they're talking about, so ask them a very simple history. Does the itching worsen or improve once they rub their eyes? So allergic patients usually will say that itching worsens the symptoms. Dry eye patients usually will say itching, rubbing their eyes will improve the symptoms, because with rubbing, they get a mechanical stimulus that sort of increases the tear outflow. So that is one very, very simple thing you can say. Then turn the lids, look for papilla. Just someone with dry eye usually will not have any papilla. And also one thing to be kept in mind is both of these conditions can coexist. So that is not entirely ruled out. But if you look at the surface staining, so any of these breakup time and especially conjunctival and corneal staining will be more with the dry eye group than with the allergic group of patients.
Thank you, sir.
Any other residents?
Another thing, if you want to differentiate between allergic and immunological group, I think immunological condition is the one of the most resistant type of dry eye to treat with. The symptoms, if you put on patient of allergy on anti-allergic, the symptoms go very fast. But in the dry eye of that category, your anti-allergic will not work and your dry eye symptoms will persist over that. So one way you can differentiate over that also, that patient is having some immunological disease also.
There's something called functional visual acuity assessment or some, when you're suspecting a dry eye and then you put a lubricant drop and then suddenly the visual acuity improves. So these are also something which occurs with dry eye patients, especially this thing. I think that. What is your opinion on that?
Definitely, sir, because many patients, they'll not realize, they'll say that I'm seeing blurred and we'll try doing refraction again, but whereas the patient just has simply dry eye. So in the clinic, we can just apply lubricating drop a couple of times and then ask them how they feel about it. Yeah. That's also very quick confirmation by treatment, basically.
And also when we are doing the vision just after the blink is good, and then it deteriorates after maybe a second or so. The moment you ask them to blink, they can see it very clearly, and then it starts blurring out. So that is again one sign where we can just put a lubricant and see.
So Tharani, you have some questions, please?
Yes, sir. Regarding the lacrimal gland staining, sir, how much the deficiency, how can we quantify the deficiency for acne?
Quantification? No, normally one is just clinical grading, how many openings you are seeing. So normally you should be able to see 5 to 6 openings. So anytime you're seeing less than that, that is like some of the ducts are blocked or not functioning at all. But if you really want to quantify, then you'll have to take videos or still images over time. And then you can map out the area about how it is increasing. So there is a publication by Dr. Swati on this, how to quantify basically. So they have taken serial images at certain intervals, and then you take it to Photoshop or ImageJ software and you mark out the areas of the part where the fluid has basically formed. And from there, indirectly, you can calculate how much the tear secretion is.
Dr. Sanjeev Kumar, you have any? We welcome you to ask. We encourage you to ask questions, and if you have any queries, please go forward. Renuka Dhaka.
Sir, I also want to ask one question.
Please go ahead.
Hello, sir.
Yes.
Sir, many times we get refers from medicine and other departments to rule out the dry eye in associated autoimmune conditions. But when we do Schirmer's test, Schirmer 1 in the OPD, most of the times it's in the normal range. But patient is giving history of all the dry eye symptoms. So how to proceed in such cases, sir?
So that's what. So Schirmer is among the clinical tests to an ophthalmologist, it is the least reliable test, basically. So you should be doing the other tests. You should be doing fluorescein breakup time. You should be doing ocular surface staining. You should be looking at the meniscus height. Those are more reliable tests. Because with Schirmer's, very commonly what happens is the reflex tearing happens. So in that case, you can do a repeat Schirmer's after putting an anesthetic eye drop.
Okay, sir.
So you can have a comparison of that. But still, I will, for explaining it to a patient, Sharma's is fine. But for you to make a diagnosis, Sharma should be the last test to be done.
Okay, sir.
Ideally, you
Thank
should
you,
be
sir.
doing the other tests, basically. So
Okay,
start
sir.
staining
Thank
start staining the surface. That's very important.
Yes. President sir, Dr. Pranav Ranjan, do you like to give your?
President sir is not here. We have the president-elect,
He's not.
Sir
Okay,
Jayanta
okay.
Parma, sir.
Hello.
Okay. So, President,
Hello.
Dr. Jayant Barwa is there.
Yes, yes, he is here. Sir is here.
Sir, Dr. Jayant Barwa, sir, would you like to give your opinion?
It's okay. Is basically the treatment for a dry eye, especially MZD. It is basically heat and the massage. Am I right?
Yes, sir.
Yes.
So how does it help in expression of the meibomian, the secretion, mebum?
So this would work for like the mild to moderate cases, the heat and massage. So once we are heating it up externally, so that basically, so in MGD, what happens is the secretions become very thick, the glands get obstructed. So by heating up, we are basically sort of liquefying those secretions, and by massaging, we are manually sort of expressing those secretions ourselves. But doing it one time will not help. It has to be done repeatedly, because in these patients, there is always a tendency for it to get collected over and over again. So it has to be done on a daily basis, preferably twice a day. And the device-based therapies are basically doing this in a more sort of regulated way, be it thermomiboflow or the LipiFlow therapy. So these are basically machines which are doing essentially the same thing. They're heating up the glands and then expressing and massaging out the poor quality secretions. So once the poor quality secretions are out, then we can have a good quality mebum which is replacing it. And once we do it regularly, then usually the patients over time, the good quality secretion builds up. That's how it overall helps.
How long does it take actually? I mean, how long the patient usually, in your experience, require to do this therapy?
At home-based therapy, they should be doing it daily, sir. There is no time frame for it.
Okay.
No, actually, I advise them for about 15 minutes minimum, not 2-3 minutes.
No, not at all. Yes, that's also very important. Yes. So that 2 to 3 minutes will not help at all.
Minimum 15 minutes.
Definitely.
For a month, again, repeat it after some time. And that I get some good result out of that. And secondly, does it have anything to do with the melting point of mebum?
Melting point, that's how they set it. The LipiFlow is set to 42 degrees Celsius. So to do it in a home-based therapy would be slightly difficult. But anything around, I mean, it should not be too hot. So around 40 to 45, if they can achieve, that is good enough. But they should not be too enthusiastic and burn their lids.
Thank you.
Sir, actually, after massaging for 5 to 6 times, we have to squeeze the lid also. So usually I advise to squeeze the lid margins, upper and lower lid margins, so that the meibomian gland meibomian secretions will be expressed. And sometimes also we can squeeze in the OPD also under local anesthesia or topical anesthesia. We can squeeze by using 2 swab sticks. Using 2 swab sticks, we can squeeze if it is not responding in home based. After that, patient will do.
So there are some of these cute rollers available from various instrument stores, which you can just sort of easily help in massaging it out in the clinic.
Dr. Swaraj, Bhattacharya is there.
Was there, ma'am, but I think he's left. But I think our president, sir, is just come in. I can see his name.
Sorry, I was
Oh.
actually
Yes, yes.
traveling, so I'll listen to I'll watch the recorded version definitely, and I'll give my comment because this is a very good topic. And Dr. Soham Basak, I heard him in the initial 5 minutes. He was really good, and I'm going to listen to it, the recorded version. So thank you everyone, and especially Dr. Vaishi Mehti and Speaker Dr. Soham Basak. Both of you have done a commendable job for as
Thank you,
far as
sir.
ARC is concerned. So that is why I did not want to miss, but I was on a flight. I just landed.
Okay.
So,
Nice to have you, sir.
congratulations to all of you.
Are there any questions from any of the residents? Dr. Renuka Daka, since the
Yes,
Sanjay
sir.
Kumar, you have any queries?
Yes, sir. Yes, sir.
Please go ahead.
Sir, my question is that lissamine green is specific for conjunctival tissues, and rose bengal is specific for corneal, whereas we are more concerned with the cornea as far as dry eye is concerned. Then,
Not really. If you look at it, both of them stain both the kind of tissues. So rose bengal stains anything where the mucin is deficient, anything that is dead or dying. So that's what rose bengal stains. Lissamine green stains anything that is dead or dying. That's how it is. So it's not specific to conjunctiva or the cornea. However, these stains on the cornea is difficult to detect because of how the anatomical appearance is. So these are both of them. The conjunctival staining is something which we are able to appreciate more with both lissamine and rose bengal. For cornea, the fluorescent stains make it more obvious because it's a transparent tissue. You have the iris as a dark background, so it's difficult to detect. But however, both of them will stain the entire ocular surface. It's not limited to one kind or the other.
sir, but it is said that lissamine green is more preferable for detection of
the
white
lissamine is
light tissue.
Yeah, lissamine is more preferable because one, the irritant. So rose bengal, if you apply it on yourself, you will realize it's quite an irritant stain, and it itself is slightly toxic to the surface. So lissamine is more tolerated.
Sir, apart
And
from the
apart from the
intolerability, it is said that lissamine green is more preferable for conjunctival devitalized tissue, whereas rose bengal is
devitalized.
more for yes, sir.
No, lissamine green. So you have to understand the basic how these stains functions. Lissamine green is a vital stain. It will not stain anything which is alive. It will stain anything which is dead or dying. So that's why. So conjunctival devitalization. So even rose bengal will stain.
Sir, but
So it's
goblet
just
cells
that
are present only in the conjunctival.
only the
tissue.
conjunctiva. Yes, goblet cells are present only in the conjunctiva. But if there are damaged goblet cells in the conjunctiva or damaged epithelial cells of the cornea and conjunctiva, both will be stained by lissamine. But it is more appreciated. Both of these are more appreciated on the conjunctiva, especially because of the contrast of the thing.
Yes.
And most of the dry eye patients have a congested cornea to begin with. So the green color actually gives a better contrast. And if we look at the dews, they recommend using a red filter also to further enhance the lissamine green stain, the staining part of it. So it's based more on that. The preferability is based more on how well we are able to appreciate it, not based on how the dyes themselves function, basically.
Thank you, sir.
Any comments from Madam Zetri, Dora, or
Sir, already I have commented my comments.
okay?
But I think it's 9 p.m.
Okay. Okay.
Should
So
we
I
close?
think Thank you so much. Thank you so much.
Thank you.
I'll propose a vote of thanks on behalf of ARC EIZOC. First of all, it has been a very wonderful evening. And on behalf of ARC EIZOC, I'd like to thank the speaker of today's webinar, Dr. Soham Basak, for giving us a very wonderful and insightful talk on such an important topic as dry eye, which we all see very commonly on a daily basis, and we can hardly ignore them. There are so many things which I think, even ourselves actually, after so many years of practice, has been hearing for the first time. So it's indeed a very eye-opening thing for all of us. Next, I want to thank the moderator of today's function, Professor Jayasri Dora, for moderating the session so well and coordinating all the speaker and the panelists and the other office bearers, and of course the residents. And our thanks also goes to our panelists of today's function, today's webinar, Dr. Nidhi Katkar and Dr. Abhishek Ranjan for their uh, nice inputs and helping us iron out some of the difficulties which our residents are having, and then helping us understand the topic much better. Thank you all, sir and madam. Also, our sincere thanks goes to our residents who are here today, who has been actively participating, and with your active participation, we are encouraged to take this kind of activities more forward. And these webinars are intended for you mostly. So I hope you really enjoyed this, and we want to thank you for your participation and making this complete. On a more homely this thing, I want to thank the office bearers of EIZOC, the president, our Pranab Ranjan sir, president-elect Dr. Jayanta Barua sir, our honorary secretary who was here briefly, Dr. Swaris Bhattacharjee, for they have been always been supporting us with all our endeavors. Thank you so much, sir. All the audiences we would like to thank, and last but not the least, we would like to thank Anthod Pharma for really supporting all our ARC webinars so far and making this without any financial difficulties with us. On this note, thank you all so much. It's been a really wonderful evening and such an insightful talk and discussion that we have had. Thank you so much.
Thank you,
Thank you,
sir.
sir. Thank you, sir.
Thank you. Thank you. Good night.
Good night,
Good
everyone.
night.
Thank you. Thank you.
Good night.
Thank you. Good night, everyone. Good night.
Good night.
I'm repeating. Very last.